Hi everyone, welcome to FMGE July 2024 recall session. I'm sure you're all relaxed now, and this is the time for you to not worry about how you performed your exams. It is just all about trying to understand how the questions were and what are the answers. And I'm here to help you understand the way questions have been asked in the latest FMGE July 2024 in terms of biochemistry and clinical biochemistry. And let's together find out the right answers, and do not panic if you get any of these questions wrong. It's all about learning, okay? Let me start the session by telling you that the questions discussed in the PowerPoint are recall based, and the aim of the session is, as I told you, for you to understand questions and understand the answers. And in the process, we would also collect all correct answers, perfect answers with questions and answers. And the final question received will be uploaded on the PrepLadder app. And to first give you, one second. So to first give you an overview of how questions were asked in terms of biochemistry, total MCQs asked were 22. And as always, maximum number of questions were asked in vitamins. Yes, I've always been telling you, questions are asked in vitamins because in every metabolic pathway, there is one or the other vitamin that is involved. So when I say it's a vitamin-based question, indirectly it's a metabolism-based question, and that has got the maximum contribution. And 4 questions were from inborn errors of metabolism. From genetics, there were 2 questions. And interestingly, in the topic of alcoholism, alcohol-related MCQ, be it blood alcohol concentration measurement, or alcoholism causing beriberi, or alcoholism causing hypoglycemia, put together, there are 4 MCQs. And acid-base, good afternoon. Biochemistry questions are next level. I hope you were able to answer all these MCQs because every MCQ we had already discussed. So acid base, there were 2 MCQs, and chemistry part, there was just 1 MCQ which was all about lactulose. And then diagnostic test base, we had 2 MCQs, and the others, there were 2 MCQs. So the way questions are asked has not changed much in terms of blueprint. It is always vitamin which carries the maximum contribution. Okay. So let's start discussing questions one by one. Interpret the following values provided in the ABG report. Let me first give you the right answer because I know you're all anxious to know the right answer. The right answer for this question is metabolic acidosis. And for those of you who want to know why is it metabolic acidosis, here the blood pH is low. We all know that the normal pH is 7.36 to 7.44. In this case, pH is low, so we know for sure it is acidosis, which means you can exclude metabolic alkalosis and respiratory alkalosis. Then proceed on to check PCO2. We know the normal PCO2 is 36 to 44. I have always asked you to exclude 7 in the pH value to remember PCO2 value. So PCO2 normally is 36 to 44 millimeters of mercury. In this case, PCO2 is low. Can a low PCO2 cause acidosis? Low PCO2 can only cause alkalosis. So we know that the low PCO2 observed in this ABG report is not the cause of acidosis. It's not the primary acid-base disorder. Now look at bicarbonate. The normal bicarbonate is 21 to 27 milliequivalents per liter. In this case, bicarbonate is low. Can a low bicarbonate explain acidosis? Yes, because bicarbonate is a major plasma buffer. So for any reason, if a person misses his or her bicarbonate, there is no buffering of metabolic acids, and that will cause metabolic acidosis. So what is the right answer for this question? It is metabolic acidosis. Are you all clear about this? Of course, I was told that there were many other values which are also given in the report. We don't have to worry about any other values. Just look at pH, bicarbonate and PCO2 and you'll get the right answer, which is metabolic acidosis. Is that clear? Now the next one. A neonate presents with recurrent projectile vomiting, which is non-bilious. What is the electrolyte abnormality that is expected in this condition? Of course, they did not give you a straightforward diagnosis as pyloric stenosis, but the history tells you it's a probable case of pyloric stenosis. And you don't have to memorize what electrolyte abnormality it would cause, right? So you can just exclude choices and arrive at the right answer. PCO2 low. Yes, I'm right. Yeah, that's what I had also given you here. Low PCO2 cannot be the cause of acidosis. It's only low bicarbonate, so it is metabolic acidosis. Okay, so whatever it is, whatever may be the cause, it cannot necessarily be pyloric stenosis. Even otherwise, what do you expect in vomiting? Yeah, out of these 4 choices, let's find out which is the easy target for us. Whenever there is vomiting, you know, chloride gets lost in the vomit, right? So there is going to be definitely hypochloremia. So out of these 4 choices, we know it is going to be hypochloremia. It is not hyperchloremia. Then, will it cause metabolic alkalosis or metabolic acidosis when there is vomiting? Vomiting will cause metabolic alkalosis. So we know this is not the right answer. So what is the right answer, all of you? Non-bilious vomiting is what I was told. Yeah. So what do you think will be the right answer? The right answer is hypokalemic, hypochloremic metabolic alkalosis. And for those of you who are interested and curious to know why hypokalemia and why metabolic alkalosis, it is because when the person vomits continuously, there will be dehydration. And this dehydration causes secondary hyperaldosteronism. And what does aldosterone cause? Aldosterone causes sodium and water reabsorption, and reciprocally it causes potassium and H+ secretion. So what will happen when there is excess potassium secretion into the renal tubule? There will be hypokalemia. When excess H+ gets secreted into the renal tubule, that causes metabolic alkalosis. So please remember, whatever may be the cause, it can be vomiting, it can be diarrhea, yeah, whatever it is. If there is dehydration, what will you expect? You will expect secondary hyperaldosteronism, and that causes hypokalemic metabolic alkalosis. So this child will present with hypokalemia, hypochloremia and metabolic alkalosis. If only hypokalemia was given, then that is the right answer. They'll definitely present with hypokalemia because of secondary hyperaldosteronism causing excess potassium secretion. Okay. Methotrexate acts by inhibiting. Yeah, we all know the right answer. Methotrexate is a competitive inhibitor of dihydrofolate reductase. Now, how can it act as an anti-neoplastic drug by inhibiting dihydrofolate reductase? Tetrahydrofolate is not formed. Without tetrahydrofolate, what cannot be formed? Purine ring and pyrimidine ring cannot be synthesized. Without purine and pyrimidine ring, replication cannot happen. So, actively dividing labile cells get affected, and your neoplastic cells come under this category. They get affected. That is how methotrexate acts as an anti-neoplastic drug. It's a competitive inhibitor of dihydrofolate reductase. So this is an interesting clinical case-based MCQ, right? And this we have discussed so many times in the session. A 3-month-old boy was presented with severe hepatomegaly and cataract in both eyes. The child appeared lethargic and hypotonia was observed. Identify the enzyme that is involved. Yeah, you see hepatomegaly, you see cataract. What will you choose? It is classical galactosemia caused by the defect of galactose 1-phosphate uridyl transferase. I've asked you to remember it as GalPut, right? Galactose 1-phosphate uridyl transferase defect causes classical galactosemia. I can see that Mohit has answered it as galactokinase. Of course, galactokinase deficiency also causes galactosemia, but in galactokinase deficiency, you will observe only cataract. You will not observe hepatomegaly. The child will not be lethargic. You will not observe hypotonia. Whenever galactosemia is because of the defect of just galactokinase, you will observe only cataract as changes and urine will answer Benedict's test. Because they have given hepatomegaly as well, the answer is galactose 1-phosphate uridyl transferase deficiency. So, answer for this question is choice D. Zellweger syndrome is due to which of the following suborganal defects? We know that Zellweger syndrome is a peroxisomal biogenesis disorder. So, what is the right answer here? The right answer here is peroxisome. Okay, the right answer here is peroxisome because Zellweger syndrome is a peroxisomal biogenesis disorder caused by the defect of, same question, yeah, caused by the defect of POX gene. Okay, and POX gene helps in synthesizing or organization of peroxisome. And in this condition, what will you see? It's called as cerebrohepatorenal syndrome, right? It's called as cerebrohepatorenal syndrome. And I've already told you so many times that peroxisome is related to very long chain fatty acid oxidation. So in this case, very long chain fatty acids do not get oxidized. Branch chain fatty acids do not get oxidized. So all these fatty acids would accumulate. Peroxisome is also related to ether lipid synthesis or plasmalogen synthesis. So, in this condition, there will be low levels of plasmalogens. And glycine and taurine conjugation of bile acid also does not happen. So, answer for this question is peroxisome because Zellweger syndrome is peroxisomal biogenesis disorder. Okay. Very good. Cerebrohepatorenal syndrome. Yes, you're right, doctor, Chota doctor. Now, composition of lactulose. So, all of us must have learnt about lactulose being used as a laxative, right? And predominantly lactulose is used in a patient with hepatic encephalopathy. And what is lactulose made up of? The clue is there in the name. It ends with UL. I've told you in the session that when anything ends with UL, it's a clue that there is a ketose. And we know the well-known ketose is fructose. So, lactose, the actual lactose is supposed to have galactose and glucose, and lactulose has got galactose and fructose. Only to denote that it has got a ketose, there is an UL in its name. And why is lactulose used as a laxative for hepatic encephalopathy? I've explained this also. Lactulose is a non-absorbable disaccharide. When a person ingests lactulose, it's not getting digested in the intestine. Undigested lactulose reaches colon, wherein colonic microorganisms convert lactulose into an acid. So, this causes acidic pH of the colon. Whenever there is acidic pH in the colon, any ammonia that is formed in the intestine will react with hydrogen ions to form ammonium ions. And these ammonium ions cannot be absorbed from the colon. So, it gets lost in the feces. Thereby, what is not getting absorbed along the intestine? Ammonia is not getting absorbed along the intestine. So, tell me what are the two sources of ammonia for any individual? Major sources of ammonia would be number 1, amino acid breakdown. Number 2, the ammonia that is absorbed along the colon. So, by giving lactulose, we are not allowing ammonia to get absorbed along the colon, and this ammonia gets excreted as ammonium ion, and that is why lactulose is prescribed for a patient with hepatic encephalopathy. It's a disaccharide that is made up of galactose and fructose. Okay. Cherry red spot without hepatomegaly or without organomegaly is seen in which of the following disorders? Yeah, this we have classically described, right? Cherry red spots without organomegaly is nothing but Tay-Sachs disease, okay? And I've also told you that cherry red spots are absent in KGF. So what is KGF? Krabs disease, Gaucher's disease and Fabry's disease, right? So Gaucher's can be excluded. Fabry's can be excluded. Von Gierke's disease. Von Gierke's disease has got nothing to do with cherry red spot, right? Also, Von Gierke's disease will present with renomegaly. Organomegaly and hepatomegaly will be observed in Von Gierke's disease. So, the answer here is Tay-Sachs disease. Yeah, only lipid storage disorder. Okay, the lipid storage disorder with cherry red spot without any organomegaly would be Tay-Sachs disease. A couple presents to the OPD with their 4-year-old child who has self-mutilating behavior. The moment you see self-mutilating behavior, what will you think of? Lesch-Nyhan syndrome. So what is Lesch-Nyhan syndrome? I told you it's a defect of purine salvage pathway, and the enzyme which is defective in this condition is hypoxanthine guanine phosphoribosyl transferase. So this is an enzyme of purine salvage pathway. When this enzyme is defective, the child will present with self-mutilation and hyperuricemia. Okay, and I've also told you that it is an X-linked recessively inherited disorder. Yeah, whenever I've told you the list of inborn errors of metabolism which are X-linked recessively inherited, I've always told you about Lesch-Nyhan syndrome caused by the defect of hypoxanthine guanine phosphoribosyl transferase. Thank you. The condition is treated by supplementation of which of the following? It's a classical image-based question that gets repeatedly asked in FMGE. I'm sure all of you answered it right. So, Castle's necklace, right? So, wherever it gets exposed to the sunlight, if you see hyperpigmented scaly lesions, so like that is seen here, Castle's necklace is caused by pellagra, right? And pellagra is caused by niacin deficiency. So, we know pellagra, 3 Ds of pellagra, diarrhea, dermatitis and dementia will be caused by the deficiency of vitamin B3 or niacin or nicotinamide. Okay? Yes, answer is nicotinamide. B6 was also given in the option. Even if B6 is provided, of course B6 deficiency can also cause pellagra, but if you see nicotinamide, go for it. Yeah, because it's like supplementation, right? Direct supplementation of niacin is better always to treat pellagra. Question, yeah, biliary. Yeah, I have that MCQ also. I'll discuss that MCQ. Okay. Pyridoxine is also given, but I would prefer to choose niacin because it is like you finally giving the end product, right? If you give B6, all that you can do is you can help in the conversion of tryptophan to niacin. But what is better? Giving niacin is better. Which of the following can be mediated by CRISPR-Cas9 technology? So this we have discussed so many times. I've told you CRISPR-Cas enzyme system. It is used for gene editing, right? It is used for gene editing because Cas enzyme is an endonuclease that can make double-stranded DNA break at specific sites. Okay, so if you can synthesize a Cas enzyme which can target specifically on the site of mutation causative of a disease, what will the Cas enzyme do? It will go and cut the site of mutation and it can be repaired. So it is used for gene editing. So CRISPR-Cas enzyme system is used for gene editing and only for identifying and repurposing CRISPR-Cas enzyme system for gene editing, Emmanuel Charpentier was given this Nobel Prize. And all that you have to know is Cas is an endonuclease which causes double-stranded DNA break at specific sites and it can cut and repair specific sites which are mutations causative of a disease. Okay, so answer here is gene editing. Yeah, DNA editing or gene editing, in either case that will be the right answer. A chronic alcoholic patient who's used to taking arak or local alcohol for the last 25 years suddenly presented with agitation and confusion. A similar MCQ has been already asked in FMGE. Right. So, chronic alcoholic presenting with global confusion after withdrawing alcohol for 2 days. This has been previously asked in FMG. They have repeated a similar pattern, but they have just changed the scenario. Otherwise, it's the same. Okay. So, there were gait abnormalities. On inquiry, the person gave a history of alcohol withdrawal for 3 days. So, identify the condition. So, alcohol withdrawal causes delirium tremens. And delirium tremens presents with, I've given you a mnemonic to remember the manifestations of delirium tremens. It is GHN, right? Government, hospital, nurse is what I asked you to remember it as, right? So, what does G stand for? Global confusion, hallucination, nightmares. So, here they have given you confusion, agitation and gait abnormalities. They also present with tremors. So, what is the right answer here? The right answer here is delirium tremens. Please do not go for thiamine deficiency just because there is confusion. Okay, the classical, the phrase that you need to pick up here is alcohol withdrawal for 3 days. So, the answer is delirium tremens. Option injection thiamine as next immediate step. That will not help this individual, right? So, this is because of alcohol withdrawal. Do you all understand this? Answer is delirium tremens. Which of the following substances? So, another MCQ on alcoholism, and this I would say is quite a complex MCQ, right? This has not been asked before. So, which of the following substances is used for sample collection in tube for blood alcohol concentration measurement? Did you all see this question? Yeah, for blood alcohol concentration. First, let me tell you what are the methods used for alcohol measurement in the blood. The reference method is gas chromatography. Yeah, please remember the reference method for alcohol concentration estimation is gas chromatography. But usually, clinically, what we do is we use enzymatic oxidation method. You can either use enzymatic oxidation method or chemical oxidation method. And what is chemical oxidation? We add potassium dichromate, which oxidizes alcohol to form an acid. And in this process, potassium dichromate becomes chromate. It becomes a free chromium. Okay, so there will be a color difference that is observed, and we estimate the intensity of color difference that is observed in this condition, based on which we find out what is the alcohol concentration. So definitely you need potassium dichromate. And what is the tube that has to be used for this purpose? We are not allowed to use any tube which has got a clot activator or a gel and a clot activator, because all these will have alcohol which will interfere with the assay. So, the preferred anticoagulant or the preferred additive for this purpose is fluoride. And why are you supposed to add fluoride? Because fluoride inhibits the growth of microorganisms in the sample. What if you allow microorganisms to grow in the sample? All these microorganisms can utilize glucose and they can generate alcohol, or they start utilizing any alcohol that is present in the sample. Do you understand this? Because RBC in the sample will be competing with the microorganism to use glucose. So what will these microorganisms do? They start consuming the alcohol that is present in the sample, causing false low values. And that is why we are supposed to collect blood sample in a tube which has got fluoride. Fluoride inhibits the growth of microorganisms so that it does not cause false low values of alcohol. So what is the right answer here? The right answer here is sodium fluoride and potassium dichromate. Okay. So I would say this is a complex MCQ. I am seeing this MCQ for the first time to be asked in competitive exams. So what is the, it was potassium oxalate. Even if it was potassium oxalate, you can still go ahead and choose that, because that is the additive that we use. One more question. Is this the question that you're talking about, Dua? A 50-year-old man who is a chronic alcoholic was presented with complaints of confusion, tingling sensation. His history revealed Polish rice in his main diet. What is the diagnosis? So, Confusion, tingling sensation, neurological manifestations, you can suspect B1 deficiency. And there is also history of polished rice intake, and the person is also an alcoholic. Put together, what is the diagnosis? The diagnosis is beriberi. Okay. Yes, dry beriberi, exactly. Very good. Very good, Tejeshwar. Thymol was there in the option. Okay, thymol is a urinary preservative. Yeah, we are not going to add thymol. Thymol is an alcohol that should definitely not be added. Edema and history of polished rice. Okay, even in that case, that's going to be, if it's edema, it's wet beriberi. If it's neurological manifestations, dry beriberi. In either case, the answer would be beriberi. Okay. The patient had a history of strenuous exercise but forgot to take his meal and later had alcohol in a party. Which of the following processes inhibited by alcohol? So this person presents with hypoglycemia. Okay, a person had a history of strenuous exercise, has forgotten to have his or her meal, and then the person has taken alcohol, and then the person is presenting with hypoglycemia. So which of the following processes is inhibited by alcohol? The answer is gluconeogenesis. Yeah, answer is gluconeogenesis. This we have discussed so many times in our sessions. I've always told you chronic alcoholism can precipitate repeated episodes of hypoglycemia. And the reason is whenever alcohol gets metabolized, it forms an aldehyde and then it forms an acid. And both these reactions are done by alcohol dehydrogenase and aldehyde dehydrogenase. Both these enzymes generate NADH. So please remember, the metabolic status of a chronic alcoholic is that of high NADH-NAD ratio. Whenever there is high NADH-NAD ratio, pyruvate will get converted to lactate. Not just that, oxaloacetate will get converted to malate. So a chronic alcoholic always has low pyruvate and low oxaloacetate. And we know for gluconeogenesis, we start from pyruvate, then we convert pyruvate into oxaloacetate. Only then it can go through steps of gluconeogenesis. So in a chronic alcoholic, when there is low pyruvate and low oxaloacetate, gluconeogenesis cannot happen, and that is why they present with repeated episodes of hypoglycemia. So what is the reason for alcohol precipitating hypoglycemia? High NADH-NAD ratio causing low pyruvate and low oxaloacetate inhibiting gluconeogenesis. So the answer for this question is gluconeogenesis. The person was given was given glucose. Okay. So hypoglycemia is because of inhibition of gluconeogenesis. Okay. Which of the following manifestations are seen in vitamin A deficiency? I would say a very simple MCQ. Vitamin A deficiency causes which manifestation in the eye? Bite spots, right? Because you know vitamin A suppresses keratinization of epithelium. So whenever there is vitamin A deficiency, keratinization happens everywhere. Conjunctival epithelium undergoes keratinization, causing dryness of conjunctiva, which is xerophthalmia. And the keratin debris accumulates as Bitot spots. So Bitot spot is because of lack of inhibition of keratinization of epithelium. Okay. And we know about other choices, right? Oats striae. So where do you see oats striae? Yes, keratoconus. That's a manifestation of keratoconus. And then Al's line, it is trachoma. It's a manifestation that is seen in trachoma. Horner tantra dots. Yeah, that is seen in vernal keratoconjunctivitis. Question was probably related to alcohol intoxication. Next step was asked. Thiamine was in the option. I don't remember clearly. Okay, so alcohol intoxication and then glucose was given and they have asked you, is it because of inhibition of gluconeogenesis? That would be the right answer. Thiamine deficiency has got nothing to do with hypoglycemia. Okay. So this I would say is a very interesting case-based MCQ. right? So they've asked you to apply the knowledge that you already have. So let's read this case-based MCQ. I've always been telling you, whenever you're given a case-based MCQ, do not panic. Read the question with an open mind and start excluding choices. Okay. So let's try to do that here. A 16-year-old patient happens to have pellagra-like eruptions on skin in spring season from last 5 years with normal HIAA. Blood value may dilute salt wala. Dilute salt cannot be used for alcohol estimation. Yeah, answer is Hartnupp's disease. Let me reduce your anxiety. Answer for this question is Hartnupp's disease, and then let me tell you why is it Hartnupp's disease. Okay. So pellagra-like manifestation, which is nothing but niacin deficiency, and it is accompanied by normal HIAA and high amino aciduria, right? Indole levels in urine are normal. What is the probable diagnosis? So what would be the right answer? The right answer would be Hartnupp's disease. Because what are the causes of niacin deficiency? We know niacin is synthesized from tryptophan. So tryptophan goes through several chemical reactions. Finally, it gets converted to niacin. So if you ask what are the causes of pellagra, the first and most common cause of pellagra would be niacin deficiency in the diet. Or it can be tryptophan deficiency in the diet. Example, maize-based diet. And even if the diet has got tryptophan, what if there is tryptophan malabsorption? There is no tryptophan, no niacin synthesis. And that tryptophan malabsorption syndrome is called as Hartnupp's disease. Do you all understand this? And in Hartnupp's disease, what is the defect? It's a defect of a neutral amino acid transporter which is present both in the intestine as well as in the proximal convoluted tubule. And what is its function in the small intestine? In the small intestine, its main function is to absorb tryptophan. So when that transporter is defective, tryptophan is not absorbed along the intestine. So that causes tryptophan deficiency, and that causes niacin deficiency or pellagra. When tryptophan is not reabsorbed along the proximal convoluted tubule, all tryptophan will be found in urine, and that causes amino aciduria. I've clearly given this statement in all your sessions. If you see pellagra-like manifestations to be accompanied by amino aciduria, you should always think of Hartnupp's disease, which is caused by tryptophan malabsorption, wherein there is also a defect of tryptophan reabsorption in the proximal convoluted tubule. Okay, and another cause of niacin deficiency is wherein tryptophan is not used for niacin synthesis and tryptophan is used for serotonin synthesis. When will it be used for serotonin synthesis? In the case of carcinoid syndrome. But had it been carcinoid syndrome, 5-HIAA levels will be elevated. Because they have told you that level is normal, we know it is Hartnupp's disease. Do you all understand this? So the answer for this question is Hartnupp's disease. Laryngismus stridulus is due to which of the following vitamin deficiency? So laryngismus or laryngospasm is caused by calcium deficiency or hypocalcemia, because calcium is necessary for maintaining the resting membrane potential. Whenever there is hypocalcemia, all muscles will be activated, causing laryngospasm. And hypocalcemia will be caused by vitamin D deficiency. Very good. Answer is choice A. Post-translational modification, a single glance at this MCQ might have given you a panic attack, right? But if you look at all the choices, if you try to exclude choices, it will be super easy. So what is the question here? Post-translational modification common to collagen, hemoglobin and immunoglobulin. One question was there in which Castle's necklace, I discussed about that MCQ. It is niacinamide or nicotinamide supplementation. Of course, pyridoxine can also be supplemented, but I would choose nicotinamide because that's giving the final product. Is that clear? Nirbhav. Yes. So, collagen, hemoglobin and immunoglobulin. So, the key here is post-translational modification. Just that term will help you to exclude splicing. because splicing is a post-transcriptional modification. Similarly, gene editing is a post-transcriptional modification. Okay, so you are left with hydroxylation, subunit aggregation. I am going to exclude hydroxylation because that is a post-translational modification that happens only for collagen. Right, it is not going to happen for hemoglobin or for immunoglobulin. So what is common for all these three proteins? Collagen, hemoglobin, immunoglobulin, all these are multi-subunit proteins. Immunoglobulin can have till 10 subunits. Yeah, collagen is a triple helix. Hemoglobin has got 4 subunits. So it is subunit aggregation. Got it, all of you? Methylation is not happening in the case of collagen formation. Methylation is one of the post-transcriptional modifications that are related to tRNA formation. Okay, of course, some proteins can undergo methylation. That does not happen here. The answer for this question is subunit aggregation because all these three are multi-subunit enzymes. Okay. The process of converting unconjugated to conjugated substance is done by which of the following? So they are asking you conjugation reaction. Which of the following is a conjugation reaction? So what is a conjugation reaction? It is a phase 2 detoxification reaction where an exogenous substance which is non-polar is getting converted to a polar form, right? And for that we use glucuronidation. So what is the right answer here? The right answer here is glucuronidation. It is not glycation, it is not glycosylation. Glycation and glycosylation are adding carbohydrate residues to endogenous proteins. It has got nothing to do with exogenous substances. Oxidation is not a conjugation reaction. It is a phase 1 reaction. So answer is glucuronidation. Okay. Yeah, I will discuss that. And then monkeypox detection is best done by. Yeah, this I've discussed in genetics session when I've told you in and out about real-time PCR. When we discussed about real-time PCR, I told you it's a quantitative PCR which can help you to quantify nucleic acid of any of the pathogens with the highest sensitivity and highest specificity possible. Right, so the answer for this question is real-time PCR. The only difference between the real-time PCR that you use for SARS-CoV-2 detection and the real-time PCR used for monkeypox detection is that SARS-CoV-2 is an RNA virus. So for SARS-CoV-2 diagnosis, there will be a reverse transcriptase PCR followed by real-time PCR. But your monkeypox is a double-stranded DNA virus. So you can skip the reverse transcriptase PCR step. You can directly quantify it. So it's real-time PCR, which is the right method. And I saw that in few of the online sessions, many have been asking about heme agglutination. Heme agglutination is a diagnostic method that is used only when the virus can express heme agglutinin. So what are the viruses which express heme agglutinin? Only flu viruses, right? Influenza viruses express heme agglutinin. Only in that case this can be used. ELISA, antigen-based ELISA or antibody-based ELISA, they cannot be specific because that can be cross-reactivity. Okay, so the right answer here is real-time PCR. Which of the following is the most sensitive cardiac marker? So the key here is most sensitive. Your answer should be TROP-I because TROP-I is the first marker to be elevated whenever a person suffers from myocardial infarction. Okay, so answer is choice C. Even if it is CKMB, so CKMB, it takes some time for its level to be elevated. So the most sensitive marker. But if there was myoglobin, of course, myoglobin elevation will be the first, but we can rule out myoglobin because it's not a specific marker at all, right? So the right answer for this is TROP-I. Which of the following is a cause of unconjugated hyperbilirubinemia? Early cardiac marker. If it's early cardiac marker, it is TROP-I. It's definitely TROP-I. So the difference between TROP-I and CK is TROP-I will be the first to be elevated. But the disadvantage of TROP-I is it remains elevated for quite some time. Okay, so this will not be able to detect recurrent or progression of the infarction. Yeah, so if you're trying to analyze if there is progression of the infarction or progression of the anginal event, then you cannot estimate tropi. So for finding out if there is progression, then you have to estimate CKMB. That's the advantage of CKMB over tropi. Yes, earliest marker. Good. Which of the following is a cause of unconjugated hyperbilirubinemia? It is Gilbert syndrome, right? So we know that Crigler-Najjar syndrome and Gilbert syndrome, right? Both these cause unconjugated hyperbilirubinemia because both these conditions are caused by the genetic defect of UDP glucuronide transferase enzyme gene. Right? So whenever UDP glucuronide transferase is defective, no conjugation happens. So unconjugated bilirubin levels will be elevated. Whereas conjugated hyperbilirubinemia will be seen in Dubin-Johnson, Rotor and biliary atresia. So the answer here is Gilbert syndrome. Okay. So that's all about the 22 biochemistry MCQs that were asked in the latest FMGE July 2024. To summarize, many questions, 5 MCQs are from vitamins. So if you are a person who is preparing for the next FMGE or if you are a person who is preparing for NEET PG or INI-CET, whatever competitive exam it is, the topic that you should all learn about without fail is vitamins. And do not learn vitamins directly. First, learn all metabolic pathways and then when you're summarizing it, summarize it by learning vitamins. And in FMGE this time, there were 2 MCQs on genetics. So FMGE aspirants do not underestimate genetics. Okay. So please learn all these topics in a conceptual and applied manner. And if you ask me how are these questions, I would say all these questions are of very high standard. Most of these MCQs are conceptual, which you will be able to understand only when you learn all 19 subjects conceptually. Yeah. So thank you and thanks for being with me today. And please relax now. Yeah. Take your time to pamper yourself. And thank you. In case of alcohol poisoning, I told you the answer is already given. The blood sample has to be collected in a tube with fluoride and potassium dichromate. My pleasure, Chota doctor. Have you ended the session?